chief with their prior chiefs so that they know the way each one of the attendings sets up their room, organizes their equipment, and so on. And if there's not enough time to do that, maybe one of the ways to use your Friday morning time is for each attending to make a guest appearance and to discuss how we like things set up and why. If you think that'd be useful, I would certainly be happy to do it. I realized yesterday with Jeff and with Ray that although we've operated a lot, maybe I haven't made clear what I like with my Greenberg, my retractor, my microscope, and all that, and why. So I'd be happy to stop by to do that, if that would be helpful. I think the other attendings would as well. All right, Chris, take it away. Well, I'm not sure that everyone needs us to introduce her, not within the residency, but the first I heard about Halima was from Mike Lawton. And I don't get too many calls from Mike. Of course, I'm going to answer anytime he calls. But he called, I didn't answer for a couple of days. And he called again. I answered and he was not there. We played phone tag for a while and he was very persistent. And finally I got him. He said, Josh, I need to tell you about someone. Her name is Halima Tabani. And she's been working for us for a while. She did some skull base. She's with me now doing cerebrovascular. And I have rarely, if ever, seen anyone as talented or dedicated as Halima. You really must look. And I really would like you to consider her. And it's very rare to get a reference from someone like Mike that strong and that opinionated. And it had a big impact on what we did. So when Halima arrived as her PRF, as our PRF that year, she proved herself beyond even what Mike had said. And as you know, she's now been with us in the residency doing a great job. So welcome, Halima, for your talk today. What are you going to be doing this morning?
Good morning, everyone. Thank you so much, Dr. Berson. I'm going to be talking about carotid cavernous fistulas this morning. Just give me a second to pull up my presentation. Can you all see my screen now?
Yeah.
Yep. Okay. So good morning, everyone. I'm Halima. I'm one of the interns, and today I'm going to be talking about carotid cavernous fistulas. And I'll be presenting a case that we did with Dr. Shoya, and then use that case as an example to discuss the diagnosis and management for CC fistulas. So this is a brief outline of my presentation. Like I said, I'll start with the case and then review a little bit of cavernous sinus anatomy and then go over the presentation, diagnosis, and management of carotid cavernous fistulas. So here's our case. We have a 61-year-old female with a history of hypertension and hyperlipidemia who presented to an outside hospital with 1 week history of headaches and diplopia. So Jorge, if you got a call on the transfer phone regarding someone with such symptoms, what would you want to ask them next?
So I would need further history, headache and diplopia, would be concerning for a cranial nerve deficit, either the 3rd, the 4th, or the 6th. I would like to know the characteristics of the headache. Where is it located? Is it continuous? Does it have like a pulsatile, nature? And I would need to get a very good exam of, the eyes, pupillary reflex, and so on. Yeah.
Exactly. So that's what they did. they got further history, and they found out that she had a 2-year history of worsening headaches and bilateral tinnitus, but this 1-week history of headache was progressively worsening headaches for a week and new onset of diplopia. So they went ahead and got an exam, and she was found to have medial deviation of the right eye at rest, but she was able to overcome it with effort. They also got an ophthalmology consult, and they measured the intraocular pressures as well as did visual field testing and visual acuity, all of which were within normal limits. So, Jock, what should we do next? Jock, you're muted.
As the patient has some cranial nerve involvement, I will get an imaging of the brain, maybe starting with a CT head without contrast initially.
Yep, exactly. So we went ahead and got a CT head without contrast, which is here on the left, which was unremarkable. And they also got a CTA, head and neck. The CTA initially was read as normal, but then they addended the read to say that the CTA showed bilateral orbital venous congestion and enlargement or engorgement of bilateral superior ophthalmic veins, which you can see, scrolling, but you could see here that the superior ophthalmic veins bilaterally were engorged. And a little bit of this might be just due to the gantry, but or the positioning, but if you notice, she does have a slight exophthalmos on the right side. So then they called us, and we were consulted, and the patient was brought over to Mount Sinai for further management. So once she got to Mount Sinai, we took her for a diagnostic angio, and these are the AP and lateral projections of the common carotid runs. And as you can see on these, there is early venous filling of the cavernous sinus. There's bilateral engorgement of the superior ophthalmic veins, and it's hard to ascertain exactly what's feeding into this. So based on that, you could make a diagnosis of carotid cavernous fistula, and then on closer examination, you can see that the fistula is being fed by branches of both external and internal carotid arteries. So it's being fed by the meningohypophyseal trunk and some branches from the ILT as well. And then it's also being fed by branches of the IMAX. And then it's draining into bilateral superior ophthalmic veins. And then later on, it also goes on to drain into facial veins. And these are just the ICA runs. And then previously I went through the ECA runs as well. So moving on to carotid cavernous fistulas. As the name suggests, a CC fistula is an abnormal connection between the cavernous segment of the ICA and the cavernous sinus. It is a rare pathology, and it occurs in about 0.2% of patients with craniocerebral trauma, as well as about 3.8% of patients with skull fractures. And they're mostly unilateral, but bilateral fistulas can also occur, especially in patients who have traumatic etiology of the CC fistula. So before discussing further the pathophysiology behind carotid cavernous fistula, I just wanted to review the anatomy of the cavernous sinus. I'm sure most of us have seen this diagram on the left several times. The cavernous sinus is basically basically a network of trabeculated sinusoids. It is covered by dura on both sides, and it's basically located in the middle cranial fossa lateral to the sella. And it contains several important neurovascular structures, including the cavernous ICA, as well as multiple cranial nerves, including 3, 4, 6, V1 and V2. And one of the questions that we are commonly asked is about the relationship of these nerves with the ICA and their location within the cavernous sinus. And as you can see on this figure that cranial, most of the nerves are located in the lateral wall of the sinus, apart from the abducens nerves, which is related closely to the carotid cavernous cavernous segment of the carotid artery. And so it's one of the first nerves to be involved in either a pathology of the cavernous ICA, such as an aneurysm, or any pathology involving the cavernous sinus. So the cavernous sinus receives input from several veins, including the orbital veins, superficial and deep middle cerebral veins, and the sphenoparietal sinus. And then it outflows into the superior and inferior pectoral sinus, draining into transverse sinus as well as the internal jugular vein, respectively. There's also outflow into the pterygoid venous plexus and into some emissory veins around the foramen ovale and rotundum. And these connections are important to remember in terms of when you're looking at the drainage of CC fistulas and then considering their management. And then the bilateral cavernous sinuses are interlinked with each other through anterior and posterior intercavernous sinuses, which form the circular sinus. Another important aspect of the anatomy of cavernous sinus to consider when thinking about CC fistulas is the cavernous ICA and its branches. So I know the figure here kind of gives it away, but Matt, do you want to recap for us the branches of the cavernous ICA?
Sure. So you have the meningohypophyseal trunk and the inferolateral trunk, which I think are both abbreviated there. And then you can also have capsular arteries as well.
Exactly. So like Matt said, there's the the MHT and the ILT, and then they have their own branches, including the artery to the tentorium, dorsal meningeal artery, and the inferior hypophyseal artery from the MHT, and then branches to the tentorium, as well as the cranial nerves from the inferior lateral trunk. So one or more of these branches may be involved in CC fistulas, especially the indirect ones. So carotid cavernous fistulas can be classified in several ways based on either their hemodynamic flow, which they could be categorized as either high flow or low flow. Based on the etiology, they can be categorized as spontaneous versus traumatic. Based on the anatomy, they could be categorized as direct versus indirect. And then the most common way to classify them is based on their angiographic features, which makes use of the arterial supply, and that is the Barrow classification. So the Barrow classification basically takes into account the type of fistula as well as its arterial supply, and there are 4 types, A through D. Type A is a direct fistula between the cavernous ICA and the cavernous sinus. Types B through D are indirect, and to be more specific, type B is an abnormal connection between meningeal ICA branches and the cavernous sinus. Type C is from meningeal ECA branches. And then if you have involvement of both ECA and ICA branches, then it's type D. So coming back to our patient, what would be the Barrow classification for this patient? Abi, do you want to take a shot at it?
Yeah, so that would be, it's being fed by both internal and external. So that would be type D.
Exactly.
As long as.
So it was, so for our patient, it was an indirect fistula, and it was being supplied from the ILT, MHT from the ICA, and IMAX from the ECA. So it would be Barrow type D. So moving on to the etiology of CC fistulas, there are different etiologies for direct and indirect fistulas. Direct fistulas are most commonly traumatic, caused by trauma. Up to 80% of them result from either blunt or penetrating trauma. And then some of them are also due to iatrogenic trauma, such as during endoscopic and nasal approaches or even CEA. And then the rest of the 20% are due to spontaneous. They could be either due to a cavernous IC aneurysm that ruptured, and the resulting defect caused a fistulous connection between the cavernous sinus and the carotid. It could be due to weakness in the vessel wall due to collagen vascular disorders, including FMD or Ehlers-Danlos loss, or it could be due to other minor trauma. As opposed to direct fistulas, indirect fistulas have an uncertain mechanism. There are a few mechanisms that have been postulated, including breakdown of the thin meningeal arteries that traverse the cavernous sinus, as well as opening of the anastomotic dural channels, which could occur due to either venous sinus thrombosis, and it does not necessarily have to be thrombosis of the entire cavernous sinus, but even partial thrombosis or microthrombosis, as well as elevated venous pressure. And risk factors for indirect CC fistulas include diabetes, hypertension, pregnancy, and atherosclerosis. So the most common presentation especially for direct fistulas is what's known as the Dandy's triad. And the patients present with pulsatile exophthalmos, an orbital bruit, and chemosis, as depicted in these pictures. For most indirect fistulas, patients can have other less subtle symptoms such as diplopia, headache, facial or orbital pain, visual loss, epistaxis, tinnitus, and then some severe features such as the patients can present with ICH or subarach, venous infarcts, or increased ICP due to venous hypertension. So if they are not treated promptly, they can lead to several complications, the most significant ones of them being ophthalmologic complications. And they can include medically refractory glaucoma, which can occur due to elevated orbital venous pressure, neovascularization, and congestion of the iris or the choroid. A lot of patients do present with ophthalmoplegia, which can lead to diplopia. And the cause of ophthalmoplegia in these patients can either be due to extraocular muscle swelling or entrapment due to orbital venous congestion, or direct involvement of the cranial nerves by the fistula while they're in the cavernous sinus. So either of these causes can cause ophthalmoplegia. And then patients can present with vision loss, which could be due to venous stasis retinopathy, due to the glaucoma, which can lead to optic nerve damage, or spontaneous choroidal detachment. And then similar to AV fistulas, there are certain features for CC fistulas which make them high risk. The most significant one of them being cortical venous reflux, and the same applies for dural AV fistulas. And if left untreated with these high-risk features, especially cortical venous reflux, there's about 30 to 40% risk of hemorrhagic stroke. And it's important to note that cortical venous reflux is associated specifically with superior petrosal sinus drainage. And then rarely these patients can present with subarachnoid hemorrhage, especially if they had cavernous sinus varices. It's rare, but most often patients who present with subarachnoid hemorrhage have a higher rate of mortality. And then if there's drainage of the fistula into sigmoid and transverse sinuses, there is a risk of venous hypertension and then resulting elevated intracranial pressure. So as we discussed in the case of our patient, there are multiple imaging modalities that we can use for diagnosis. However, especially in the case of direct fistulas, sometimes the clinical findings are strongly suggestive of CC fistulas, and we use these imaging modalities as a supplement. So this table basically summarizes the advantages and limitations of the different imaging modalities that we can use. The one that we most commonly use is CTA, and it would show distension of cavernous sinus. It could show early enhancement in the arterial phase, as we saw in our patient, and dilatation of the draining veins. However, the limitations of CTA are it might not detect high-risk features, and there's poor temporal resolution. MRI is also helpful, and it's similar to CTA, shows distension of the cavernous sinus and engorgement of the intercavernous channels as well as the superior veins. It can also show enlarged extraocular muscles and exophthalmos. However, all these features are predominantly present for high flow fistulas, so MRI might be insensitive for moderate to low flow fistulas. The most useful non-invasive imaging modality has been time-of-flight MRA or contrast-enhanced MRA because they show flow-related enhancement in the cavernous sinus. And although time-of-flight MRA does not have temporal resolution, including contrast to that helps in improving temporal resolution. So it has been used commonly to diagnose CC fistulas. And then the gold standard for diagnosis of a CC fistula is a catheter angiography. So DSA helps us determine the type of fistula. It helps us basically localize the exact location of the tear in case of direct lesions and the arterial supply in case of indirect lesions. It helps evaluate the degree of AV shunting and analysis of venous drainage pathways. And the most important feature that sets it apart from all the other imaging modalities is that it helps identify high-risk features, including cortical venous reflux. So that is our gold standard in the diagnosis for a CC fistula. So moving over to management, there are several different management modalities, including conservative management, surgical management, radiosurgery, and endovascular treatment. And we'll go over them one by one. So starting with conservative management, it has been reported that there's a wide range of indirect CC fistulas between 10 to 70% that spontaneously close. However, direct fistulas rarely spontaneously close. So that's one thing to keep in mind. And then when in patients who have low flow fistulas without significant orbitoocular congestion, without any high risk angiographic features or symptoms that are not tolerable, they can be often followed conservatively. However, during this period of watchful waiting, it's important to keep clinical as well as imaging follow-up to make sure that they're not developing any aggressive or high-risk features. And also a technique that has been used during this time of conservative management is manual compression of the ipsilateral cervical ICA several times a day. And it has been shown in some studies to successfully obliterate 17% in the case of direct and 30% of indirect CC fistulas. So then in which cases would you consider non-conservative management? Anyone who has progressive vision loss, cranial nerve palsies, rapidly worsening proptosis with corneal exposure, any high-risk features including cortical venous reflux, and intractable retroorbital pain. And these are just a few. The treatment basically has to be tailored to the patient's clinical and radiographic findings. So the choice of treatment depends on each individual patient. So coming to surgical treatment, historically, the method for surgical treatment of CC fistulas was ligation of the common carotid artery up until the 1960s when Parkinson published this paper where he described an approach using the Parkinson's triangle to the cavernous sinus. And then this remained the standard approach for a while until other approaches were developed. And more recently, combined intra and extradural approaches are used to approach the cavernous sinus. And then depending on the type of fistula, they're treated accordingly. So if it's a direct fistula, surgical treatment would involve clipping or suture repair of the fistula. And then if it's an indirect fistula, surgical treatment would involve disconnection of all the arterial feeders. However, surgery is associated with high morbidity and it's technically challenging. So it's most often performed only after failure of endovascular treatment. Radiosurgery is also an option for the treatment of CC fistulas, and there have been several case series which have shown that radiosurgery is successful in the improvement, in symptom improvement in about 95% of the cases and fistula closure in about 93% of the cases. However, it's important to note that it takes anywhere between 12 to 36 months for successful obliteration of these CC fistulas, and so it can only be used in a certain select patient population who have low flow fistulas and who do not have high risk features. So moving over to endovascular treatment, which currently is the treatment of choice for the treatment of both direct and indirect fistulas, and the choice of treatment method has to be tailored depending on the type of fistula, the size of the tear, the rate of shunting, as well as how accessible the venous channels are to get to the cavernous sinus. And the general risks of endovascular treatment include stroke, hemorrhage, injury to the vessel, as well as parent artery occlusion. And it's also important to remember that it's important to counsel patients that right after treatment, their symptoms may temporarily or rarely permanently worsen as the fistula thromboses, and there's alterations in venous drainage. So there's been several different methods that have been used and different materials that have been used for endovascular treatment of CC fistulas, including detachable balloons, coils, liquid embolic agent, including NBCA and Onyx. And then more recently, the use of covered stents has also been tried out. And then in terms of access, for most direct fistulas, transarterial access is used through the ipsilateral carotid artery. For most indirect fistulas, a venous route is used, and any of these listed veins could be used depending on how accessible they are, whether there's thrombosis of any of these veins. And in case none of these venous routes are accessible, then direct percutaneous puncture of superior ophthalmic vein is another possibility. And then if venous access is difficult in case of indirect fistulas, then their transarterial catheterization could also be considered. So again, summarizing the different treatment modalities, first for direct CC fistulas. The first treatment modality that was used for the treatment of direct CC fistulas and endovascular treatment was the use of detachable balloons. And what basically did was go through the transarterial route and go past the fistula and then inflate a detachable balloon. And this technique was shown to be safe and effective. However, it had some limitations in terms of there was difficulty in navigating some catheters which were stiff to the fistula. And sometimes because of the small venous compartments within the cavernous sinus, it was difficult to inflate the balloon, as well as there was a potential for balloon deflation or migration after deployment. However, in 2003, the use of detachable balloons in the USA was stopped, so we no longer use this treatment modality. So the most commonly used treatment modality nowadays is the use of either coils or liquid embolic agents, both of which have their own advantages and disadvantages. With coils, because they have we can use small and flexible microcatheters. It's easier to use and more accessible. However, there is potential for coil prolapse into the cavernous sinus. and especially in the setting of high flow shunts. And then there's potential for residual, as well as this treatment modality might be expensive, especially if you're using platinum coils, because you have to use a ton of coils to pack the entire, either the draining vein or the entire cavernous sinus, depending on the patient presentation. Another alternative is the use of liquid embolic agents, including NBCA or onyx, because they have excellent penetration of small venous compartments of the cavernous sinus. And however, they have the disadvantage of using such agents is that there's less controlled embolization. There could be extravasation of these agents into non-target arterial supplies, and that could lead to deficits depending on which artery has been involved. If none of the, if using coils or liquid embolic agents is ineffective, another alternative treatment choice is to sacrifice the carotid artery. It has been shown to be an effective method, and of course, we perform a balloon test occlusion prior to sacrificing the carotid artery. However, there's still a potential for ipsilateral ischemic stroke, even if the patient passes BTO. So it has to be used with caution. And then lastly, more recently, the use of covered stents has been shown to be effective in small series of patients. And it's a good option to use if more traditional endovascular methods fail. However, there's concern for long-term patency of the stents, and some studies have shown stent occlusion and long-term follow-up of these patients. As all intracranial stents, there's also the need for using antiplatelet therapy if you use a covered stent. So coming to the treatment of indirect CC fistulas, so mostly these fistulas are treated using the transvenous route, and both coils and liquid embolic agents can be used, and we already discussed their potential advantages and disadvantages. And then in case transvenous access is difficult or inaccessible, transarterial liquid embolic embolization can also be considered. So in terms of outcomes after treatment, symptoms of chemosis and proptosis have been shown to resolve within days to hours. Cranial nerve palsies take a longer time to resolve, and they resolve over a course of several weeks. In patients presenting with vision loss, the degree of recovery is dependent on the severity and duration of the pre-intervention deficit. And then there's always a possibility of recurrence of CC fistulas due to recanalization. It is uncommon, but if it does occur, it can be typically be treated by repeat embolization. So coming back to our patient, so our patient was treated with transvenous coil embolization. As you can see, we basically occluded the entire superior ophthalmic vein on the affected side, as well as the fistula. So these are the unsubtracted and subtracted lateral runs post-treatment, and then these are the AP runs showing successful obliteration of the fistula. And then on 1 month, so the patient did well post-operatively, and then she was discharged on post-op day 1. On 1 month follow-up, she did report significant improvement in her headache. And then on exam, her right-sided cranial nerve 6 deficit resolved completely. However, she was noted to have a new left-sided cranial nerve 6 deficit. So she was taken back for another diagnostic angio, and it was found that she had some residual filling of the cavernous sinus of the fistula. So she was this was fixed using onyx embolization, and these are the post-onyx runs. And then after this procedure, on follow-up, the patient her right cranial nerve 6 deficit had already resolved completely. Her left cranial nerve 6 deficit significantly improved, and she reported significant improvement in her headaches and tinnitus. So to conclude, CC fistulas are complex lesions that can be challenging to diagnose and manage. And it requires a multidisciplinary approach. So between neurointerventionists, neurosurgeons, as well as ophthalmologists to achieve the best outcomes. Angio is the gold standard imaging modality for the diagnosis and classifications of these fistulas. And then endovascular intervention with the goal of complete fistula occlusion while preserving normal blood flow is the treatment of choice in current day and age. In select cases, open surgery, radiosurgery, or conservative management are also treatment options. And usually patients have good outcomes with symptom resolution and low recurrence rate after appropriate therapy. And thank you so much, and I'll be happy to answer any questions. And also, I want to thank Dr. Shoira for overseeing, for letting me be a part of this case and helping me with this presentation.
Thanks a lot, Halima. That was really a fantastic summary.
Yeah, excellent job, Halima. You've really summarized the case very effectively and browsed through the literature very comprehensively. I want to add that in these cases, one of the most important things when we're doing the diagnostic angiograms is to identify the earliest point of visualization of the shunting. And we usually do that by identifying the earliest image that shows the venous structures. As you have displayed in some of the images earlier from the case, eventually the contrast spills from the arterial side to the venous side, and it engorges and fills the entire venous structure. So oftentimes you will see the bilateral cavernous sinuses light up, and then you see the superior ophthalmic veins on both sides, sometimes even the sphenopalatine sinuses, and it becomes really difficult sometimes to identify what is the earliest point of fistulization. And to do that, you essentially have to stop at the first image of the angiogram that shows a venous structure of any sort. And we usually employ high frame rates so that we can identify that structure even with more accuracy, because that structure is the point of fistulization, and that's the target of treatment. If you start embolizing or occluding other venous structures that are not the earliest, you essentially will be locking your way out of the fistula and making your treatment more difficult. So it's very important to try to target the earliest point of shunting with your treatment. And here, even though in this patient's case, her symptoms started on the right side, the earliest point of fistula formation was on the left side. And so the left cavernous sinus was truly the target of our treatment here.
One thing that's challenging about these is that you can lock yourself out of your target. You can go in on one side where the fistula is, and if you missed a fistula on the other side, but you had blocked your entry into the cavernous sinus, and maybe the other side is thrombosed. So you have to have a good understanding, a complete understanding of the ins and outs of the cavernous sinus you're treating, so you know that you can get to another point if needed. But that's one interesting aspect of the endovascular treatment that you don't really see unless you get down and dirty with one of these. But you really have to watch out for locking yourself out. Okay, thank you so much, Halima. And that concludes our grand rounds for today. Have a great day, everybody.
Thank you.